Well, ladies and gentlemen, it gives me great pleasure to be here and to let you know that we have reached that part in today's proceedings when, in accordance with a resolution of the University Council, we seek to honour Emeritus Professor Praphan Phanuphak by conferring upon him a Doctor of Medical Science honoris causa. It is also fitting that this honorary degree is being conferred at this occasion, as it was a very dear wish of the late Professor David Cooper that such an honour be bestowed. So I now call upon the Dean of the Faculty of Medicine, Professor Rodney Phillips, to read the citation.
Ladies and gentlemen, it gives me a great deal of pleasure to here today honour Emeritus Professor Praphan Phanuphak for his eminent service to the community through his contribution to medicine. Professor Praphan was born in Thailand after receiving his Doctor of Medicine in Honours from Chulalongkorn University, Mahavidyalaya Chulalongkorn. In 1968, Praphan travelled to the United States of America, where he attended the University of Colorado Medical Center's graduate school in Denver. There he received his PhD in microbiology and immunology in 1976. After returning to Thailand in 1979, Praphan founded the Thai Red Cross AIDS Research Centre, which he's been its director since 1990. He's also co-founder and director of the HIV Netherlands-Australia-Thai research collaboration, so-called HIV-NAT, along with the late Scientia Professor David Cooper from the University of New South Wales and the late Professor Joop Lange from the Netherlands, who you'll remember very sadly died in the Malaysian air disaster some years ago. Praphan is a member of the World Health Organization's Strategy and Policy Committee on HIV and the UNAIDS Scientific Advisory Committee. He chairs the National HIV Biomedical Prevention Subcommittee in Thailand and is Vice Chair of the Thailand Country Coordinating Committee for the Global Fund on AIDS, Tuberculosis and Malaria. Praphan has been a leader in setting the agenda for the HIV response in Thailand, as well as the broader Asia-Pacific region, when the HIV epidemic swept Thailand in the mid-1980s. He was one of the first responders. He diagnosed the first 3 cases of AIDS in Thailand, and since then he's been at the helm of Thailand's response to HIV through his involvement in establishing key services and organizations that encourage and facilitate both testing and the treatment of HIV in a nation where the stigmatization can be very profound indeed. An outspoken leader and an advocate for evidence, Praphan has conducted some of the region's and indeed some of the world's most important AIDS research at Mahavidyalaya Chulalongkorn, the Thai Red Cross AIDS Research Centre, and the aforesaid HIV-NAT. Leveraging his research expertise, Praphan is committed to promoting and fostering the finest of medical science. He has also facilitated the education of doctors and practitioners in HIV/AIDS testing and treatment through the Thai AIDS Society and hosts the annual Bangkok International Symposium on HIV medicine, which brings together researchers, practitioners, policymakers and other stakeholders from around the world to collaborate on the international response to HIV. Through his determination and passionate advocacy, he has secured the extraordinary support of Her Royal Highness, Princess Somsawati of Thailand, which has been pivotal in the rollout of a number of HIV services and access to testing and treatment for the Thai community as a whole. Praphan has made an important, influential and indeed indelible mark upon the community in his country through his exceptional research, advocacy and leadership. He has been instrumental in Thailand's greatly increased number of people receiving not only HIV testing, but definitive treatment with multi-drug antiretrovirals. This has resulted in a vast and, in fact, world-leading reduction in the transmission and acquisition of the virus. And crucially, along with this incredibly important work, the notion of the disease and its carriage has been substantially destigmatized in Thailand, a very important aspect of his work. He is a fierce promoter of a human rights-based approach to public health, in the tradition, of course, of the Kirby. He is a strong advocate globally for harm reduction, including the use of preventative measures for the transmission of HIV and sexually transmitted diseases. When the day comes in the annals of medical history, those leaders who contributed most in the crucial time of the epidemic will stand in judgment, and it is our belief that Professor Praphan will stand amongst the giants who defied this horrific disease and where we have now wrought a substantial victory. But that fight is not over. The disease continues, and there is much more to be done. The University Council of the University of New South Wales, noting all that I have said today, and in noting his eminent service to society, resolved that it would be fitting if the degree of the Doctor of Medical Science, honoris causa, were to be conferred on Professor Praphan. And today, we admit him to this university's highest honour.
In the name of the Council, and by my authority as Deputy Chancellor, I admit you to the degree of Doctor of Medical Science, honoris causa.
Deputy Chancellor, Mrs. Gillian Segal, Dean Rodney Phillips, and distinguished guests. It is my great honor in receiving this prestigious degree from the University of New South Wales today. I would like to thank the University Council in granting this degree to me. The person that I would like to thank most in this occasion is Professor David Cooper, who promoted me to this honorable degree. When I first heard about this great news from the University of New South Wales in last December, I immediately recognized that I was promoted by my dear friend, David Cooper. I wrote to thank him just before New Year. David wrote back to me on January the 9th, 2018, which was the last email I got from David. He wrote, quote, "Once I get back to work after taking a couple of months off, we will start planning the award," unquote. This strongly indicates that David would like to witness what is happening today. I wish David could be with us today to witness the success that he had helped me and HivNet, to the point that this honorable degree was conferred to me today, which will be a part of my talk to be followed. Thank David with all my love and respect.
So the next thing on the agenda is the Brett Tindall Memorial Lecture. Brett Tindall died aged 33 in 1994 of HIV infection. Brett's first degree was in nursing, and then he spent 4 years as an undergraduate medical student, but never finished medicine. In 1985, he began work as a research assistant at the Centre for Immunology at St Vincent's with David Cooper. And David was then a young immunologist at St Vincent's and had just started seeing the first wave of irretrievably ill young men presenting to the outpatients and emergency department there. The only treatment was antibiotics for the prevalent pneumonia that followed the violent destruction of the immune system wrought by the virus. Despite the best treatments available at the time, they all died in terrifying numbers. When David was made the inaugural director of the National Centre of HIV Epidemiology and Clinical Research, Brett moved with him. And in time, he was appointed the senior project scientist, and he slogged with David through those early years. He published with David, Ron Penny, and Basil Donovan a series of seminal papers on primary infection, on long-term non-progression, and on various therapeutic interventions. He had a great sense of urgency, driven by the knowledge of his HIV status. David always said that he was a wonderful friend, a colleague, and an inspiration to him, and indeed to many of those who worked at the old N-Checker and at the old CFI. I was never lucky enough to work with Brett, but those who did remember him and miss him still. His unparalleled contributions are remembered by the naming of this occasional lecture at each Kirby Symposium. So it is entirely fitting, given the award that has just been made, that Ajahn Praphan Phanuphak should give today's Brett Tindall Memorial Lecture. Praphan, thank you for your considerable efforts in getting here today to give this year's Brett Tindall Memorial Lecture.
So it was my great honor that knowing that David has planned this the Brett Tindall lecture for me to give. So even he planned that for almost a year. So it's my great pleasure to come here to give the talk here. At the beginning of the HIV epidemic in Thailand, the majority of the infected persons are through needle exchange, needle infections, as well as sex work. For the middle part of the epidemic, the infection was among the spousal sex, meaning husband and wife. But the last 10 years, the majority of the newly infected persons are men having sex with men. According to this estimation here, for the year from 2015 to 2019, about half of the new infections in Thailand are among men having sex with men. So that's why the main focus on HIV prevention in Thailand nowadays is on MSM. If we talk about ending AIDS, I think everyone here knows how to end HIV. You need to treat people who are infected as soon as possible, because after 3 to 6 months after treatment, that person will have too low the virus in the blood or in the secretion to transmit anyone else. So once you treat that person will not be able to transmit HIV to anyone. By doing so, in order to get people to be treated, you need people who have HIV to be tested to know that they are HIV infected. So the so-called test and treat is a very important thing to stop HIV. However, for those who test negative and still at high risk, you need to give them something rather than to just tell them to use condoms and needles and come back for repeat testing. That means PrEP is necessary. So this slide adapted from Brian Williams, that besides test and treat and PrEP, you also need some other supporting efforts in order to end HIV. Then let's talk about test often and test early. We have to admit that conventional healthcare providers would not be able to deliver all the necessary service to test those key populations because of timing, because of manpower. So you need the key populations who are committed to their peers. They have times, they have interest, a genuine interest, to reach out their friends and ask them for testing, and also bring them to treatment and prevention if they need it. So we call this in Thailand key population-led health services, or key KPLHS. Certainly, they need to work along with the authorities in the province, not just by alone. This slide is to compare to you what we mean by KPLHS versus the community-based services. When you talk about community-based health services, person being reached by the key populations, they will be tested by a mobile facilities from the hospital that go out on Saturday, Sunday, or some evenings, which would not be enough to do the services for those people who usually work at night or come out at night here. So we need to train those key populations in the community to be able enough in order to give counseling and do finger prick blood testing, and also to provide certain simple treatment as well as advising or providing the PrEP. So this way we call KPLHS. In Thailand, we have 7 health centers or community health centers throughout 4 provinces in Thailand, in the north, in the south, as well as in Bangkok areas here. They work mainly with men having sex with men, transgender women, as well as male sex workers and transgender women sex workers. This is just give the example within 1.5 years period of time. Almost more than 2,500 MSM and transgender women being tested by these community-led services here. As you can see, they can identify about 400 infected persons, mainly in MSM, less in transgender women, and they can bring them to the hospitals for ARV treatment within about 87%. And the viral load suppression is also very high. So that means they are capable to take care of their peers very well. Not different from the hospital setting there. When you look at the incidence among the key population that the KPLHS service can reach them, the incidence among MSM that being reached by these KPLHS services is very high, about 6% per year. For transgender women, for male sex worker, is also even higher, double the incidence. But for the transgender woman themselves, it's only 2.4%. But if they are transgender woman sex worker, it's also double. So that means the services delivered by key population can really reach those high-risk populations. So this is also the proper target for PrEP, as I will discuss later. Now, after testing, let's talk a little bit about treatment. These are the milestones of HIV treatment in Thailand in order to reach so-called the treat early. When I first diagnosed HIV cases in Bangkok in February 1985, almost 10 years after that, there was no treatment for them, except a single drug, ACT, which is for the rich one. However, in 1996, HivNet, which we have heard about HivNet quite a lot. This is the first time that we can provide free ARV in a large scale on a clinical trials basis, because the pharmaceutical companies can give us drugs in order to do clinical trials. It's about 10 years later, then in Thailand, we had this universal coverage for ART. In 2014, this is the first time that Thailand will say, we will treat all. We treat all. Even we will treat all, the median CD4 of the person started treatment is still very high, around 160 cells. That means this either are diagnosed late and then treated late, or they may be diagnosed early but started ART late. That's why the need for the so-called same-day antiretroviral therapy. This is HivNet, as we have heard a couple times here. Is it because of Professor Yup Lang and Professor David Cooper, whom I know since 1912? Okay. They helped to talk to the drug companies that to help Thailand to set up a similar clinical trial center like what they have in Amsterdam and in Sydney. And fortunately, this happened in 1996. This is the young David Cooper in 1996 when they opened the door for HivNet. This is the other co-director of HivNet, Professor Yup Lang, on the left-hand side. This taken 2 years after that, in 1998. What has HivNet achieved during the last 22 years? Several thousands of lives have been saved from the clinical trials for the last 10 years before ART was universally accessible. It serves as a catalyst for the government of Thailand to implement a treatment for all, because they know that the patients being treated by HivNet, they all survive, they're all healthy, so the government of Thailand cannot just sit still and do nothing. We also have Asia's largest training course, so-called Bangkok International Symposium on HIV medicines, every January for the last 21 years. And this also serves as a basis of the Treat Asia, which David was the co-founder of this organization that gathering more than 20 countries in Asia for this collaboration here. This is the 15th Bangkok Symposium. David went to the symposium every year to give a talk, okay, except January 2018. This is the last symposium that David attended last year, 2017. This is a live webcast. And David was interviewed by me and by the other actor here. It's a live webcast. Usually, after Bangkok Symposium, everyone worked very hard, and all the professors are there. So we will have the HIVnet retreat the next day. That means a Saturday, Sunday. So just to talk about what we have achieved, what's the plan, as well as to have some entertainment here. So this is what Greg Doe wrote to me. Some of my fondest memories of David was seeing him at HIVnet retreats, totally relaxed, having a few drinks, and even the odd bonding secret with him away from the constraints of Sydney life. Constraints of Sydney life. You can see here, drinks, laughing. So, now we have treatment, but it's not the answer yet, okay? As I mentioned, people are being tested and treated quite late. So what are the reasons behind that? Now, it may be from the patient's factor, maybe from the doctor's factor, hospital factor, and some other factor too. For example, if someone walks in at our Thai Red Cross Anonymous Clinic, which is a stand-alone HIV testing site, if they are tested positive, they will be referred to a hospital. Each Thai person will have an assigned hospital that they have to go to receive treatment. If they go to the hospital may be too congested, maybe too far away, because someone may work in Bangkok, but the assigned hospital may be in the north. The doctor there, especially at the private hospitals, the doctor, they may not believe or treat at any CD4 level. They will say, yeah, you're still healthy, we should wait a little bit further, repeated CD4 testing, and then they lost to follow up, or they may got ill or even die. So what we set up, so the same-day antiretroviral therapy is, for those who are tested positive at Thailand Cross Anonymous Clinic, which is about 20 or 30 people tested positive at every day. We then rule out any tuberculosis and cryptococcal meningitis. And then we give them ART for 2 weeks, free of charge. So once they are on ART, it's easier, much easier to transfer them to the hospital. Because people that take an ART, they cannot stay away. So the hospital has to continue the ART for them. Or even they don't want to go to that hospital, we can refer them or transfer them to other hospitals that they're happy with. So this is so-called ART initiation hub model. The eligibility criteria for same-day ART is, the most important thing is the patient has to agree for treatment, so it's not coercive ART. There has to be ART naive, and especially, most importantly, they must not have TB as determined by symptoms, chest X-ray, and by gene expert, as well as cryptococcal meningitis by symptoms, by cryptococcal antigens. And once they fit into this eligibility criteria, ART will be given, as I mentioned, free for 2 weeks. And then, we just do some most important basic laboratory tests is chest X-ray, creatinine, and cryptoantigens. All the other tests, as you do here in your country, viral load, resistant testing, can be done, but they don't need to know the results. If anything abnormal, we call them back the next day. Otherwise, they will return at day 14 for the follow-up. That means they have to come back for day 14 follow-up. The regimen that we're giving in Thailand, okay, is TF, FTC, and efavirenz. On day 14, on the second visit here, we just tell them the lab results, ask about any side effects, and whether or not they can go back to their hospital. If not, we give them another 1 to 2 more months of free ARV. And then we will help them to transfer to the hospital that they prefer. So we hope that by at least 2.5 months, that person should be able to transfer to the hospital that they want to go. So we call warm handoff to the primary care center here. Within the 7 months period that we perform this kind of same-day ART, more than 1,000 people been enrolled in our clinic. 90% of them accept same-day ART. Only 10% of them say, we don't want that. As you can see here, 80% of these people can be put on ART within the same day of the HIV diagnosis. Another 10% being put on ART within 1 to 2 days. And the other 10% within 3 to 7 days. We look at the retention rate at 3 months or at 6 months, more than 90%. So treat early and then prevent those who are negative but high risk. Then my challenge is, can we really prevent those at high risk with just more intense condom program and needle exchange program? I don't believe so. Because if it's successful, it can be ended long time ago. So if not, are we brave enough to talk about PrEP loudly? Experience from Australia, from New South Wales, tell us that by implementing this together with test and treat, you can end it for sure. In fact, David led a team of members of parliament to Thailand and had a visit with our Princess Somsawari to talk about the success of PrEP in New South Wales and in Australia. And our princess asked David, please help Thailand to do the same thing as you do in Australia. This is a picture of our Princess Somsawari back in 2010 when she visited Sydney. What's the PrEP program in Thailand? In the year October 2014, Thailand National Guideline add PrEP as a guideline, but it's not free. But ART is free since 2014. 2 months later, at our anonymous clinic, we set so-called PrEP 30 scheme. That means everyone who comes to our clinic, they have to pay for 30 baht or $1 a day for PrEP. So this is a logo, PrEP 30. And then a year later, January 2016, we used Princess Somsawari's donation fund for preventing mother to child, transfer it to this preventing HIV transmission among MSM. So we call Princess PrEP program. The government of Thailand started some program of PrEP in January 2017. We hope that by the end of this year, we will be in the same level of Australia, that PrEP will be given free of charge to everyone if they are MSM and transgender, but not yet to drug users or the other population, if we're lucky. The Princess PrEP program up until March this year, we have been given to PrEP to about more than 2,000 MSM and transgender women. Transgender women is about 14%. The others are mostly MSM here. I think I missed one slide here. With the implementing PrEP since 2014 up until December 2017, for the last 4 years, PrEP catch-up was just in the last 2 years here. And as you can see, the majority of them, either from the PrEP 30 at the anonymous clinic or the Princess PrEP program led by the community people, and also a large proportion of them from a single private clinic in Bangkok. So it's a fee for PrEP. It's also a profit-making service in Bangkok here. challenges of PrEP program in Thailand. Current rate of PrEP scale up, is far behind what you are doing here in New South Wales. There's no clear-cut national plan. So we talked to several people in Sydney that please help Thailand to boost up this national response here. Doctors are not the ideal PrEP prescribers, especially infectious disease doctors, at least in Thailand. And hospital is not a good place for PrEP dispensing site. Unfortunately, in Thailand, we don't have the sexual health services as we have here in Australia. So if we cannot prescribe PrEP in the hospital, can we do it outside the hospital? Can we demedicalize, or make this kind of distribution by lay people acceptable and legally acceptable? Again, I think it's same many countries here. Just keep debating, among PrEP, among condom, among whatever. I'm very pleased to show you these slides from our Thai Red Cross Anonymous Clinic, that the prevalence among those people who walk in overall and also MSM, the prevalence in our clients at the clinic was very high. For example, 12% at the beginning, but it started to drop in 2015 after test and treat and PrEP from 10% now down to about 6%. So for the last 3 years, we at the Red Cross see a definite decline of prevalence in overall clients, as well as among MSM clients in our clinic. As you can see there, it's about 20% all along. But for the last 3 years, 17, 13, and then 12% for the last year, 2017. So I strongly believe that what we are doing in Thailand, test early, treat early, as well as a PrEP, can bring down the new infections in Thailand, at least documented in our the testing site in Bangkok. In conclusion, I'm certain that AIDS can be ended if we are all serious and work hard. We know how to or what to do. Basic healthcare structure needs to be improved. Importantly, in Thailand, we need policy commitment at the highest national level, together with some strong support from sectors in the society, including community. We also need international collaboration and international push and pull effort. We need the leader like David Cooper. On March 19, we held a Buddhist ritual with the permission from the Cooper's family we call it, to send David's soul to heaven. A lot of people came to the event, even just for 1 day notification. They're David's good friends. This is my saddest moment. I never imagined that being a person 6 years older than David has to kneel down in front of his picture and offer food for him. I never thought about this before. I cried at the time, and when I think about this every time, I also cry. David, with all our loves. Thank you very much, ladies and gentlemen.